Okay, good morning everyone, and welcome to this CME. Today we are going to be looking at head injury. Thank you for the request. And maybe before we start, once again, to know who is here, just by name and the department as we progress. Go ahead.
Good morning. I'm Epidural Clinical in charge.
Good morning. I'm Rahima Junko, clinician.
Good morning. I'm Mihara Mercy. Morning. I'm Millicent Modoni, nurse.
All right.
Morning, Juma Steven, pharmacy.
Morning, Joy Obisa, nurse. Morning, Judy Kirago, nurse.
All right. Is your department picking up?
Yes.
It is, All right. So head injury is one of those things. It's an important topic. So I'll emphasize, it's a very big discussion, and this presentation we actually borrowed from a team in India. I think it's one of the most comprehensive presentations that I've seen around. So it's used for all cadres of staff, but I'll emphasize the key points. So don't worry about all the big words that we come across and all the big ideas. We'll narrow down to what makes a difference immediately, and the rest the senior team to do to pick up the neurosurgeons, the critical care teams. But what we need to know is what we must do within our setting to ensure the patient gets the best care. Sorry. Oh, that's not how it was meant. Yeah. So in trauma, head injury is an important killer, whether it's from a road traffic accident or from assault. It's one of the key things. Most patients who you see in RTAs who have to come to hospital, normally that is the case. From road traffic accidents, it's about 50% of all deaths, and about 200,000 people in the world every year suffer disabilities from head injuries. I think you've seen this. These are statistics from two countries, India and SA. We don't have our own repository, and they have about 100,000 people losing their lives every year from this. And in the US, in India, 1 out of 6 trauma victims die. Those who have this head injury, and in the USA, that's 1 out of 200. That just shows a difference in healthcare and how healthcare interventions can make a difference. I think we are closer to India in terms of our healthcare setup, and though we don't have all the data, we'll look at some of the studies. We'll find that a lot of the patients who have head injury will not be very far from this kind of ratio. But of course, as we improve our care, then you'd expect to see improvement in outcomes. And of course, the most common accident cause of this head injury is RTAs, and motorcyclists, pedestrians are the most common victims. You can see now almost everyone, every day you'll see a motorcycle guy involved in an accident. And the worst part, they're not wearing helmets. But even more worrying is a trend where the helmets that people are given are fakes. People have a plastic thing covering the head, and it's it's criminal. And National Bureau of Standards should actually be put to task for that kind of a lapse. So the most common causes, of course, we've spoken about this: road traffic accidents, falls, assault, and sports injuries. Those are the most common causes of head injury. And then just look briefly at the anatomy of the head. The most obvious. What do you know about the head? What do you see? Then this is not a medical question. This is just, I would ask class 5 this. So please tell me, what are the structures around the head, please?
Outside or inside?
Both. So you can start from outside, then you go to inside, because that's all there is to it actually. And when we talk about head injury, it's just any sort of physical damage to, this part that I'm facing, I'm touching all the way from here, all the way up. We're talking about the face, yes, the eyes. What else?
The mouth.
The mouth,
Ears.
the ears,
And the skull.
the skull. Yeah, and all these tissues, the soft tissues here. Then you can also have the scalp itself, where the hair is, and then the skull where the bone is, and then that's what we have on the outside. And most injuries will affect the outer part as well. In addition, and it's easy to forget the injuries to the outer part, and this is important. But also they tend to be less severe unless they're affecting, say, the eyeball. And but then beyond that, there's a skull, and then beyond the skull, now we have the brain. And the brain has a couple of things inside the skull. What do we have? Who knows, Doctor? There's blood. CSF. Then the brain matter itself, and then the covering of the brain matter. So that's all there is. And remember that the skull is fairly fixed. So the volume is fixed. It doesn't expand except in children when they have all these fissures. So they can actually, there will be some change in the skull volume. But for adults, it's fixed. So the contents remain the same. So you'll have the brain tissue. You're going to have CSF and blood. Then the brain is covered, and it has 3 layers. Okay. There's a dura mater. There is the arachnoid matter and the pia mater. So dura mater is the one that is attached to the skull completely. So we'll hear things like epidural, subdural, and it depends on where it is in relation to that dura mater. The dura mater is next to the skull, and it follows more or less the lining of the skull. Then you have the arachnoid mater, which is in between, and then the pia mater. Pia mater is now on the brain itself. It follows every single groove in the brain. So the immediate covering of the brain, every single sulcus, every single gyrus, the pia mater is firmly attached on the brain, and the dura mater is firmly attached to the bone. Then the arachnoid mater, meninges are just in between somewhere there, and that's an important distinction that I want us to pay attention to. That's the skull. That's the dura mater that's attached, and then the dura mater has some spaces. Those are called sinuses, and we call them the dural sinuses. So there are quite a number. There is a sagittal sinus. There are quite a number of sinuses, which I'm sure we remember from our school days. But the dura mater is generally quite adherent to the skull, except for the sinuses. And those are the sinuses there that have been highlighted. And then we have the arachnoid mater in between. Okay, the covering there, and then we have the pia mater. And then the pia mater is actually, as you can see, it follows very closely the margins of the brain. And then it's important. Where is the CSF in all this discussion? Where does the CSF run normally? Yeah, central nervous system, but in which space? Dural space. So between the arachnoid mater and the pia mater, that's where you find your CSF, just like that. Does that make sense? Because we talk about things like subdural, epidural. Sub just means below, epi just means above, subarachnoid below the arachnoid, and those kinds of bleeds. And we'll see that in a few. Okay, then that's the gray matter of the brain, and that's the white matter. So, do I replay those graphics again? We see we are good. Let's just do it one more time so that it's very clear. Outside of the skull, we have our soft tissues here. This is the muscles, the skin, the other, whatever we were talking about on the face, and of course in the front, the certain areas you'll have the orbit, you'll have the ears and stuff like this. And then that's the skull. Then after the skull, we have the dura mater. We have the venous sinuses in the spaces between. There's some small spaces where the dura is not connected to the skull, and in those spaces we have some blood running. Then we have the arachnoid mater, and then we have the pia mater. Between the pia mater and the arachnoid mater, you have our CSF, and then we have our gray matter. We have the white matter of the brain, and then the ventricles, okay, which are CSF. So in terms of distribution, 80% is the brain, 10% is blood, and 10% is CSF. They are approximate. It varies slightly from person to person. This is what we were saying, that the volume of the brain will not change, of the intracranial space will not change, because your skull is fixed. It doesn't change. The total volume remains constant. Let me ask then, if, say, for example, someone was to bleed in the brain, if the volume remains the same, let's give it a random volume. I didn't check that, look that up. But let's give it a random volume of what's the size of the brain, by the way, just approximate what you think it is. The volumes, the intracranial volume. Let's give it something like 1.5 liters thereabout. Okay, so if it was 1.5 liters about, And that's the fixed volume for someone with a big head. Let's assume it's my head. I have a 1.5 liters. If someone were to bleed in the brain, what would that mean for this fixed volume? The volume will never increase. The volume is fixed. Give me this container. So this container is going to represent a brain for now. The volume is fixed. Let's assume it's made of bone, so that no matter what you do, it will always be fixed. Even if you try and push in 10 liters, the volume will not change. That's the exact same thing with the brain. There is 80% brain matter, there is 10% blood and 10% CSF. So when someone has a blood vessel burst inside, and suddenly the blood component increases from 10%, what do you think is happening in here? Just that, pressure increases, it squeezes something. Because the volume is constant, you see the volume, the brain is a bit soft. So one way to increase, if I increase the blood component to CSF component, the easiest way is for it to squeeze something there, so that the volume reduces, but the pressure increases, and that pressure is not good for the brain, and that's the biggest problem you're dealing with in head injury. So two things will happen. You'll squeeze the brain quite a bit, and when you squeeze the brain, you're going to reduce how much blood can get to the brain tissues, and that how much perfusion there is. And then at some point, there's some small holes between the brain and the spinal and the neck. You know that's what it's called, between the skull and the spinal cord. There's a small hole there, the foramen magnum. So if the pressure is very high, this brain matter will be pushed through that. If you increase this pressure so much, there's a small hole at the bottom, nice like this, where the spinal cord is starting. You look at that hole, foramen magnum. The pressure is so much, then you're going to cause this brain tissue push so hard, it's just going to pop and pop. Just once like that. And what is that called? Herniation. So, and when that happens, it's passing, a very important part of the brain is being affected, and that's a really common cause of irreversible brain damage. But there's another area where this can also happen. You remember this thing we call the dura? There's a space, it separates the upper part of the brain from the cerebellum, from the lower part of the brain. Okay, so there's another dural, what we call it, there's a sheet, but that sheet allows when the brain matter around the midbrain is moving from the upper part of the brain, the cerebrum, to where the midbrain is and where the cerebellum is. There's a small space there also. So if you increase the pressure on the upper part of the brain, then the brain can also go through that hole and also cause herniation, because that falx is quite tight, and so the brain is also going to be squeezed there, and you can have herniation there. Okay, that is infratentorial herniation, and those are in a nutshell, that's the problem with the head injury, and that's what you're trying to reduce: the amount of pressure in the brain and the impact on perfusion. In fact, I can take this opportunity to talk about then one other item that you need to pay attention to. So, what's the role of blood in the brain? What's blood trying to do?
So oxygenation.
Oxygenation.
And nutrient supply.
Nutrient supply, and to take off the waste, right? Mm-hmm. So it's basically perfusion. That's what you're trying to achieve. Now, the perfusion, the cerebral perfusion pressure, as your blood pressure helps in perfusion across the body, right? But the cerebral perfusion pressure is the pressure the blood has that can allow for adequate supply to the brain, and that is affected by your pressure in the brain. So if just imagine this: if you increase the pressure inside the container, it's more or less squeezing out, reducing the ability of the blood to get into those spaces. You can tell that, right? And when the pressure is less, then the blood comes in easily, right? So the cerebral perfusion pressure, there's a formula for it. It's your mean arterial pressure, the MAP, mean arterial pressure, minus your ICP. So when ICP is very high, then if your mean remains the same, your perfusion of the brain goes down because there's not enough blood going in, right? Mm-hmm. And if your pressure comes down, then perfusion improves. And what you're trying to do is to maintain perfusion to the brain. So once you've understood that concept, then the rest becomes a bit easy. And let me ask you this, now that you've understood this one concept, I hope, if we were to increase the pressure in the brain, how do we maintain perfusion? How do you think we can maintain perfusion? If the ICP goes up quite a bit, let's say our mean arterial pressure was 60, it was perfusing normally, then we suddenly increase our ICP dramatically, the pressure in the brain becomes a lot. How do we ensure that we maintain perfusion to the brain? How do you think that can be done? Increasing the pressure, that's it. So in a nutshell, you've understood everything around. So there are two things we can do: reduce the pressure or increase the pressure that is applying the brain. Those two things will maintain perfusion. Tumeelewa? Okay, kama hujalewa, please stop me. It's a bit technical in that way, but it's also very simple. Okay, so I'm going to skip many of these things because they're not super important. But then just to note that we have about metabolic rate of 3.5 mils per 100 grams per minute, and about 2.9% of energy from blood glucose is consumed by the brain. And then cerebral blood flow is about 55 mils per 100 gram per minute. And again, those are not important for this particular presentation. The pressure of the brain and its contents is called ICP, intracranial pressure. We just discussed that. The pressure flowing through the brain, perfusing the brain, is called Cpp, Cerebral Perfusion Pressure. So, okay. The pressure of the blood in the body is the mean arterial pressure. Okay, that's not exactly true. The mean arterial pressure is, okay, just more or less the average. There's a formula for it as well. Do I need to mention it here? Okay. Your pulse pressure is systolic minus diastolic. That's your pulse pressure. And then, someone is needed?
Yes.
Okay. If you subtract diastolic from systolic, that's pulse pressure. So you take 1/3 of your pulse pressure and add it to your diastolic pressure. Let's assume your BP is 90/60. Okay? Your systolic is 90, diastolic is 60. What is our pulse pressure? Dr. Winnie? 30. Which is 90 minus 60. Alright? That's our pulse pressure. And it's an important parameter in terms of shock. We'll look at that later when we're doing advanced trauma life support. The mean arterial pressure is our diastolic pressure plus 1/3 of our pulse pressure. So what is 1/3 of our pulse pressure? Yvonne? 1/3 of that, yes. That is what? 10, exactly. So what is our mean arterial pressure? 70. It's 60 plus 10. So it's diastolic pressure plus 1/3 of, that's MAP. And it's the most important parameter in perfusion in general. So now you know about blood pressure, but now you know a little bit more. And you generally want mean arterial pressures for a normal patient of between 65, at least 65, unless there's a reason why there's a problem. And it's important to remember that formula just because of head injury more than anything else. So that's MAP. Cerebral perfusion pressure, CPP, equals MAP minus ICP. So, mean arterial pressure minus ICP. Is that all right? Okay. So this is what happens. This is a normal state of intracranial pressure. You have the venous system, the arterial system, the brain, and the CSF. The venous system is a bit compressible. CSF can be pushed out. The brain can be compressed. Arterial system is normally not very compressible. The volume remains constant, right? The size remains the same. When you introduce a mass, then a couple of things happen. CSF can be pushed out. The venous can be pushed. The venous side can be compressed and pushed out. The brain can be thoroughly squashed to create room for a mass, which is then creating serious discomfort and dysregulation in the brain. And this is in a situation when we, okay, to some degree, there's compensation. By compensation, okay. So maybe I should just show this a little bit better. In this situation, the brain is just a little bit squeezed. But in a situation where the ICP goes up significantly, because the mass is very big, then you can't really push out too much CSF. You really can't squeeze the venous side too much. What you end up doing is squash the brain tremendously to create room for this new mass. And this mass can either be swelling, can be blood, can be a mass actually, like a tumor growing on the brain. So. Okay. Are we okay? And the thing about brain swelling or brain ICP, your body can compensate to a certain level. Then when compensating ability is lost, there's a sudden change, as in the growth, the increase in pressure is very drastic. Compensation can happen continuously. I mean, the initial rise is quite slow, as you can see, when you are compensating. Then when your mechanisms of compensations are exhausted, then the pressure just rises dramatically, and you can actually herniate in a very short time. So, okay. And what this means, by the way, assume you have a patient with head injury here. This patient may actually look stable. They could even perhaps even talk. Okay? But the ability to compensate could be getting exhausted. And so, whereas you had this patient 1 hour ago and they looked like the GCS was 10 towards 15, when they hit this stage, you cannot see anything from that side. You cannot see anything from that side. When they hit this stage, that patient will go down and even die within a very short time. One of the big things. Okay. So, in terms of brain injury, there are two. Okay, we can categorize in different ways. There's open and closed, but the most important categorization that I want us to look at is primary injury and then secondary injury. Primary injury is what happens at the scene. Like the patient has gotten, can I say, there was a cut on the face, there is direct hit on the brain, there is bleeding somewhere. That's the direct primary injury. Then the secondary injury, and our role as healthcare workers is to reduce as much as possible the secondary injury. And the secondary injury is what happens as a result of increased pressure, and what happens as a result of decreased perfusion, and the impact of convulsions and these kinds of things. Okay, so the primary brain injury is mechanical damage, which sometimes is irreversible, and it can cause permanent mechanical cellular disruption. That may also include bruises, contusions and bruises. There's a very bad kind of injury called diffuse axonal injury, where just there's a bit of disruption of the connections of the brain, and then there are cerebral lacerations, which are basically cuts. Secondary brain injury occurs after the impact. So this is where now we have room to intervene, and many of them are preventable if you're quite prompt. So prevention of secondary brain injury results in improved neurological outcomes, and they make a difference between independent survival, just survival, and death. So in fact, patients may die if you don't intervene early. So a very good example, the same person we had who has sudden rise in pressure, the neurosurgeon is on point, he's available, you've set them to specialist, and we immediately evacuate that hematoma and relieve that pressure. That's fantastic. Number two, they actually come across a clinician who understands the role of mean arterial pressure and cerebral perfusion pressure, the interplay. So when you see the normal pressure of 110/70 with raised ICP, you know that's not enough. This patient has a raised ICP, and you know that there's a certain target, CPP, cerebral perfusion pressure. What do? You increase the blood pressure. You put an inotrope, for example, if need be, to keep your MAPs above 90. And when your MAPs are above 90, this patient gets better perfusion. And in that way, you've contributed to the outcome for this patient. You understand? You realize this patient requires glucose for the brain, and then you prevent hypoglycemia. You give some interventions to reduce brain swelling and so on. And those are interventions that make a difference. And that's exactly what you'll be looking at doing. Okay, so this is normally what happens. The brain suffers from traumatic injury, there's swelling or bleeding resulting in increased pressure, and the pressure on the blood vessels within the brain causes blood flow to the brain, reduces the flow of blood to the brain, reducing pressure. And when you have reduced perfusion in the brain, then you cause cerebral hypoxia and ischemia. When you have decreased perfusion, you have decreased oxygen. Does that make sense? And then intracranial pressure continues to rise, and then the brain may herniate, and the cerebral blood flow will decrease further. And this patient may, and we can intervene at any one of these points, and that's the purpose of our lecture. The causes of secondary brain injury: one is hypoxia, one is hypotension, another is raised ICP, low cerebral perfusion pressure, fever, seizures, and metabolic disturbances. So these, please let us take note of this, and I just wish we take a moment to write this down. These are the things that we must pay attention to, things we must avoid for a patient with head injury. One is hypoxia, PO2 of less than 80. Okay, 75 is ideal. Hypotension, systolic blood pressure of less than 90 is a no-no. Raised ICP. Okay, here the interventions could be a bit elaborate, so we'll not get much into that right now. We'll come to it later. And cerebral perfusion pressures of less than 65. And we now know how to calculate CPP. That is MAP minus ICP. And we'll know how to compute the ICPs. Fever, convulsions, and metabolic disturbances. Urea, hypoglycemia is the worst of these, and other metabolic disturbances that could be present. So, at the end of this, I'm going to ask this particular question. So I'll skip the classification because it's not super important. In terms of, okay, but people talk about mechanism, morphology, and severity. In mechanism, you can have blunt injury, penetrating injury, and both of these could be high velocity, low velocity injuries, things like gunshot, sharp instruments, So there's blunt trauma and penetrating head injuries. In terms of morphology, you can have scalp injury, you can have vault fracture, base of skull fracture. Then intracranial injury, you can have a focal lesion. You can have these things we're speaking about: extradural hematoma, subdural hematoma, subarachnoid hematoma, intracerebral hematoma, not intracranial, intracerebral. So let me ask, by the way, when I say epidural hematoma, where do you think this bleed is? Where do you think it is sitting? From that picture we looked at, do you remember? So there are three main bleeds. Okay, let's start with the easiest one. Intracerebral. Where do you think that bleed is? These big terms people like using: intracerebral, subdural hematoma, epidural, what? Extradural, and they sound clever. What do you think? Where do you think intracerebral is? Sometimes people talk about interparenchymal, but intracerebral is the right word. Okay, it could also be in the cerebellum, so maybe interparenchymal. Where do you think the bleed is? Just take a guess. And you're right, by the way. It's that simple. Eddie? It's within the white matter or the gray matter. It's within the brain tissue itself. It's not in the meningeal spaces. It's in the brain. So the brain matter. Remember those images we saw? So I'll actually go back all the way so that we can understand where we are. So this is the tilt. Okay. So this is the gray matter, the white matter. This is a gray matter. Most intracerebral bleeds will be here in these spaces. So, okay. If I say there's an intraventricular bleed, where will that be? Intraventricular spill, intraventricular hemorrhage. What do you think? Where will that be? Hemorrhage is just bleed, right? So I mean, just where will that be? Within the ventricles, yeah. Can you see? So you'll see blood there. Yeah. Let's wait for Dr. actually. This is an important one. Okay. Do you remember the layers of the brain we spoke about, the meninges? Doc, you have to come this side because mcho tu hapa karibu, hata keti tu hapa mbele. And we need a TV screen. You have a TV screen, by the way, but it's in the waiting area.
It's in the waiting area.
Okay. So what is this sinus? This meninge? What are these meninges called? This is a dura mater, remember, and it's very much on the skull. It's fixed to the skull, except those areas called those spaces where we have the venous, the sinuses. Epidural means it's above this layer, meaning it's between the dura mater and the skull. That is extradural or epidural. Extradural and epidural refer to the same thing. So, and its shape normally it's by convex. By convex, yes. Convex is, you see those thick lenses. The way the lenses, it's bulged out this side and bulging this side. It's like bulging both sides. In a bulge, you can go by pregnant. That's the epidural. Tummy on the front, tummy on the back. So remember that shape. It's super important. Why? Because this particular bleed, a lot of patients lose consciousness, then they come back to normal. Then they suddenly collapse and die. They have what is called a lucid interval. Major injury, they lose consciousness, they are bleeding. Whenever you see that shape on CT scan, emergency, immediately. And normally there are certain arteries in the dural areas, in the meninges. One very important one is a middle meningeal artery that is here around the temporal area. And this bone is very soft, the temporal bone, by the way. So even just a punch here can cause that artery to tear. And if you don't remove that blood clot, this patient will die. Just that. So it's somewhere around here. So temporal head injuries will cause epidurals. Okay. Where do you think a subdural collection is? But above the? But above the arachnoid. So between the arachnoid and the between the dura and the arachnoid, just between, it creates its own space there. Hapo katikati. Now it tends to appear sickle shaped like the moon. So on the side of the skull, it's convex. On the side of the skull, because that's where the dura is, so that shape is going to be like that. But then on the side of the brain, it will now begin to align kidogo. It takes a sickle kind of a shape. So it's like a moon that is not, the moons are, it's not very smooth on this side, so the edges can be a bit rough. You may even have some areas that are a bit bulging, but in general, it has a trend that like that. So you see that's a big distinction. Okay, then subarachnoid. Where do you think the subarachnoid bleed is? Between the and the arachnoid. And the typical distribution of subarachnoid is that it actually follows the pattern. You see that is CSF. That's where the subarachnoid bleed will be. So it sort of follows the brain. It goes into all those grooves and spaces. So you'll actually see it in those spaces. And very commonly, you'll also see it in the ventricles with some interventricular spill. Maybe not, but that is now the difference between subarachnoid. Subarachnoid bleeds sort of follow the brain. On the outside part, it's very smooth, but where there are grooves, you actually see blood going through there. Okay? Now I'm saying you're seeing blood. How are you seeing this blood, by the way? You have some psychic powers, some super. Yeah, how are we doing this? CT scan, right? So on CT scan, how does blood look? Okay. So it depends on the time of the injury. If the injury is acute, which is what you are trying to address right now, and for many cases, the acute case will be the worst, then the blood looks white. Non-contrast scan, we are not doing a contrast study in trauma. Do not do a contrast study in trauma. These are non-contrast scan. So you do, it will look white or hyper. Then hyper means extra dense. It's a bit lighter, very brighter. So bright areas, that's blood. When over some time it undergoes changes and becomes hypodense, and subdurals are very notorious for that. So you see an area that is not, when you look at some images, it is not perfectly normal, but it is not also very, it's darker than the brain. That's hypodense. That's a chronic subdural. It's been there for a long time. The blood has undergone changes, it's no longer intense. But a new bleed will look white. Sour. Then there's subacute that looks a bit grayish, somewhere in between there, but you can still tell how it's following its path. Is that all right? Hapo kama kuna swali niambie, kwa maana for this one you don't need a neurosurgeon to tell you, you don't need a doctor to tell you. This is something you should, I mean, it's like rocket, it's like science. I can tell you're wearing specs. How can I tell? How can I tell you are wearing specs? Sorry?
It's normal.
How is it normal? I'm just looking, right?
Yes.
The exact same thing with these things. When you see an epidural by convex, it's an epidural. When you see it's a subdural. When you see it's bright, it's acute. When you see it's dark, it's, you just have to know what it means, right? Yeah. If I look at you, you're not as brown as her. Yeah, okay, so it's not hate speech, it's just you're not. And okay, something like that, yeah? You can, just something it looks, just understand. There's nothing complex about it. So, all right. So we've looked at the other important part, which is basically then to see. This is skull. This is a skull, right? What kind of hematoma do you think this is? This one? That's a trick question. Iko wapi? Just say it. Be confident, guys. Be confident.
I think it's epidural because it's about the It's concave.
Nope, it's not by it's not by convex. Concave is not the concave. It's scaphoid, moon-like. That one we don't. That one is for subdural. Is this by convex? Is it fat on both sides? Tumbo mbele, tumbo nyuma? No, so it cannot be. But a very important thing. This is a skull, right? Where's the dura mater? So where is this sitting? That's just a skull hematoma. It's not a subdural. The subdural is between the skull and the dura mater. It will be inside here. This is outside the brain, outside the skull, right? That's just a skull hematoma. What about this one? Are you sure? Are you sure? Yeah, just be sure. It is. So this is what I'm saying. It's like me asking, is she wearing specs? Are you sure? Same thing. What you're seeing is just what you're seeing. There's nothing dramatic. Yeah. Once you've learned, you've learned. So just have that confidence, right? Are you able to see anything that you're discussing? I know you can't see a single thing. So how will you learn if you're okay? So so I'm going to skip this one. Okay, these are skull fractures. So normally these are there's no other way to describe this. This is quite dramatic. You can see it's depressed, right? Because you know what the skull looks like. Like in this, you'd expect to see it to be very clear. And normally they're not always this dramatic. Sometimes you see just a crack on the skull there, on the bone window, and that tells you there's a fracture. But be careful because there's some lines, there's some, what do you call this? The old fissures where you may actually see what looks like a crack, but it's not really a crack, and they tend to be somewhere here and some on the sepal regions. But definitely, whenever you see such a crack, you better diagnose a crack and consult about them, not to see that. When you have change in shape here like this is very obvious. You can already tell there's a skull fracture and it's depressed. It's going in. Even if it's going in just by a little bit, still a depressed skull fracture. It's going to be squeezing the brain. Another very important group of injuries is a base of skull fracture. Base of skull, you will not see it here, and it's actually very hard to see. Okay, you can see it on CT, but you need to have some experience looking at that. Fortunately, it comes with signs that every clinician can pick. Every nurse, every medical person can understand. So I want us to just go through those very briefly. This one. So the most common one would be CSF rhinorrhea, some fluid coming from the nose. Okay, sometimes it's mixed with blood, so you may think it's not bleeding, but when you check, it's actually a bit lighter, and it's sometimes it's clear. So CSF leaking in the nose, CSF leaking in the ears, otorrhea, rhinorrhea. Those are the first two. Then you see this blood, raccoonize, exactly. So blood collecting here. Okay. This is another very clear sign, and then this is also battle sign. Behind the ear, you see some blood collecting there. These are all signs of base of skull fracture. So whenever you see anything coming out of the ear, whether it's bloody or clear, nose bloody or clear, highly suspect that. And one of the big issues here is that then there is a break. You know, the brain is sterile. So whenever you have a break, there will be communication from the outside world into the brain, and one of the things that you must do is prevent infections, amongst other things. But then the kinds of injuries that will give you base of skull fractures, those are severe injuries. So in such a case, you categorize this as severe head injury, regardless of DCS. So, okay. We've spoken about epidural hematoma, so I'm not going to talk about it again. We just remember that these patients, they can come to you talking, I was hit, I lost consciousness, and I'm okay now. You remember that curve? They're compensating. You dilly-dally take 2 hours, then they go. They go, die. Okay? CT scan early. Sorry. What do you think this is? What do you think this this? Can you see a bleed here? This is a CT scan. Is it? You can see an acute? You sure? Doctor, please speak up. I'm not yet. You sure?
Yeah.
There's a what?
An acute bleeding.
Why do you say it's acute?
The white.
It's a, who thinks this is an acute bleed, by the way? Sometimes I feel disappointed when I've taught and people are not paying attention. Who thinks this is an acute bleed? You think it's an acute bleed? What about you also think? Who doesn't think it's an acute bleed? You don't think it's an acute bleed? Guys, is she wearing specs?
Yes.
Is it an acute bleed?
Yes.
Yes, be confident. That's it. Okay. Be confident. Even, you know, once you know something, and what I'm teaching you is to understand there's nothing different. I learned the same thing. And the good thing about these things, you see, okay? You see it. Great. So, what is that bleed? You can never see the meninges, but the shape will tell you what bleed type of bleed it is. Do you want to give it another go and be as brilliant? Is it subdural, subarachnoid, epidural, extradural, intracerebral? What is it? What is the shape? Tumbo mbele, tumbo nyuma, si ndio? Biconvex. Okay, it's like a lens. So what is that bleed? Epidural. It is an epidural. Okay, that is a medical. That is such an emergency. This patient needs to be. That should be evacuated. Start. So when you see that shape, that's what I'm referring to. Epidural. Okay, so pay attention to that shape. Swelling in the swelling the front, swelling the back. So okay. What is this? Is there a bleed here, by the way, in this brain? Is there a bleed? But let me show you guys something else I didn't say. Normally, you have this going straight in the middle. It's the midline, it's supposed to be straight in the middle. Can you see that it's being squeezed to this side? That's a midline shift. Okay? There's one last thing I'm going to show you, and maybe I'll find a scan that has, normally between the skull and the brain, you'll see a little bit of space, and you can actually make out the gyri and the sulci. Sulci or sulci, I don't know what's the right one. Is it sulci or sulci? Is it sulci or sulci? Anyway, the space is the grooves, and then the swellings. You can make out the shape of the brain. When you see that is completely gone, where you cannot see any space between the two, then we refer to that as raised ICP. It's a clear sign that there's increased pressure in the brain. So the midline shift is one. You can see that the ventricle is completely compressed on this side, and then there's no space between the brain and the skull. There's definitely increased pressure. So, okay. This is the space where CSF normally lies. You can't even see it. Okay, someone is being looked for. Okay, so here, is there anything wrong with this scan? Is there a bleed? Yes, Yvonne? There is. You think so? Where?
This side, the left side.
Here? Here?
No, not up.
Here?
Yake.
Upper? Okay, you're right. There's a bleed there. You can see that? You can see that, guys? Because you can see what the skull looks like, and then there's this bleed. So this bleed, what kind of bleed is this? It's acute, yes, agreed. Is it epidural, subdural, extradural, subarachnoid? Remember that extradural and epidural is the same thing. What is the shape? Crescent. So if it's crescent, what is it? Subdural. So, I'm being called for this meeting. Hello, Banaken. Yes, please. Good morning. Yes, has the team arrived? Goodness, I'm still in Troy room, but I'll be leaving in a few. Yeah. So you come on Ngoja. I'll be there in about. Yeah. Okay. I'll find you. Okay. Yeah, that's why I wanted us to start on time, because now this team is ready. Anyway, so we'll try and rush through subarachnoid hemorrhage. I don't think I have a copy of that, but yeah. So basically, subarachnoid, I'll look for one online and just show you. And then the other injuries. If you did a CT scan, this is an MRI, but if you did a CT scan and you saw bleeding that looks like this, you can see all these areas that have blood. This will tell you it will be subarachnoid because it's following there. Normally it's not, you'll see blood in the spaces you shouldn't see blood because it's following the grooves. That's subarachnoid, that's the difference. But this is an MRI, so that's not really a good example. The other injuries, a concussion, someone hits their head, they lose consciousness, but then it sort of reverses over time. There's no bleed. Okay, there's another kind of injury that is called diffuse adrenaline injury. It's really bad, by the way. When you do a scan, you can't see any bleed, but the patient is super sick because the neurons are torn. There's a bit of sharing on that. Okay. I spoke about herniation. When the pressure is too much, then the brain is squeezed and it tries to pass through the spaces where it finds a bit of a breather. And it's normally the what do you call this? The dural reflections or the foramen magnum. So down here we have the foramen magnum. Okay, normally what you have is a tonsil herniation, where the tonsils of the cerebellum will go down, and it will compress the brainstem structures. So this is where the brainstem is. So you'll have a lot of pressure coming in. Then you can have what is called subfile. Okay, this is a falx cerebri, and you can have some herniation here. This is one of the herniations. Don't worry about all this pressure. Just understand that this herniation can happen when the pressure is very high. The brain is squeezed through some of those reflections and through the foramen magnum. Approach to the patient with head injury. We discussed this briefly. Remember that when the head is injured, you have to stabilize the system. That's the one thing I'm just going to highlight before everything else. Then there's history, primary survey, secondary survey. We spoke about that last time. I hope you can still remember. And the history, when you're able to take that ample history, remember, mechanism of injury, loss of consciousness, evidence of seizures, probable hypoxia or hypotension, other medical conditions, ample history. We discussed that last time. I'll not get back into it today. And there's a primary survey, which we already spoke about. A, B, C, D, E, airway and cervical spine stabilization, breathing and ventilation, circulation and hemorrhage control, disability, neurological status, and then exposure and environmental control. So. Okay. This we know about. And yeah, I'll just pass through because this we already discussed. Okay. Perhaps in disability, when you're assessing your patient, there are a couple of things you want to pay attention to. Number one is the pupillary size and the reaction, and if they're equal. And the way you shine a light onto the, turn off the light, and then, I'm not telling you to do it, but you should turn off the light. And I'll just use this because I don't have my torch with me. But my patient here, I see sometimes people coming to look at the pupils like this. Please look. So I'll ask him to look at a focus on a far point, so that far dark point, so that the pupils are, dilated. And then I see people doing this. You will not see anything like that. You have to bring the light from the side, and you bring it quickly. So then you can see the reaction. But if you shine the light already, there will be no reaction, and you check both sides. In head injury, what you don't want is dilatation or unequal pupils. It tells you there's increased pressure. All right? Yeah. GCS. Have I taught how to do GCS scoring? Yes. Do we remember? Yes. We do, eh? So I'll not go back. Okay, I will, because it's important. Best motor out of 6. 6 out of 6 is what? Obeys commands, correct? 5 out of 6?
5 with response to
Not. Localizes pain. Okay. 4 withdraws from pain. 3 abnormal flexion. 2 abnormal extension. 1 no response. Best verbal? 5. Eddie?
the patient is able to speak compressed words.
Coherent speech, eh? Yeah. Coherent, smooth flowing, makes a lot of sense. 4. No, 4 is confusion. The sentences are full. Were you saying full sentences? Okay, but it's confused. Okay. 3. They are not sentences, but they're words. Eh? But you can make out the words. 2, just sounds, groaning and whatnot. And 1, no response. Best eye opening? Spontaneous? 3?
3 on speech.
Yes. To speech, 2?
To pain. 1 more response.
Very nice. Team, when I come here next time on supervisory visit, I'm going to pick any nurse, any doctor, and ask you GCS scoring. That you must know. Because you'll tell me GCS was 8. Now, and if you misassessed, you're telling the wrong thing, right? Okay. Okay, so I'm going to skip constricted pupils. Can be a sign of something else. I'll skip most of those. Secondary survey. Signs of increased intracranial pressure, headache, vomiting, seizures. Vomiting is one of those. Did the patient vomit? And normally it's projectile vomiting. Projectile means that when they vomit, inaenda mbali sana. Sawa. And then Cushing's triad, for very high pressures, there's bradycardia, hypertension, and abnormal respiration. It's a very bad sign. That patient is almost coning as a result. And then pupillary changes and papilledema if you're able to do fundoscopy. Okay. Examination in head injury, GCS, pupil size and response, then what are called lateralizing signs. Sorry, my battery is about to go off, guys. It will mean our time is up. Apologies. Yeah, that's okay. So, and then lateralizing signs and focal deficits. So normally you're saying no lateralizing signs, as in when you compare both sides, one side, compared to the other, and then an weakness in a particular area, either tone, power, sensation, reflexes. These are general for most patients. We've discussed the GCS. Please remember this, super important. And there's a GCS score for children. I'll not get into it now. For infants, because of time, but the slight variation is that instead of obeying commands, the baby is moving spontaneously and appropriately. And then, as in it's purposeful. You can tell the baby let the baby's play. You can tell that's okay. And then if a baby withdraws to touch, light touch, that is similar to localization. But if they withdraw to pain, then that is now the normal withdrawal of 4, and then the rest follow the name process. The eye opening is similar, and then verbal response is a bit of change. Babies normal baby talk. They coo and they babble, and then they are crying irritably. That's like confused speech, and then cries only to pain. That is 2, and 3, and moans to pain is 2, and 1 is no response. What's the time? Oh, we're out of time. So severity of head injury. Minor head injury with no loss of consciousness. Some people say that mild head injury is between 14 and 15. Okay, and then 9 to 13 GCS is moderate, and anything below 9 is severe head injury. 8 and below GCS, severe head injury. 9 to 13 moderate. 14 and 15 mild GCS wise. So that's how you categorize. But if you have fracture base of skull, or you have an CT scan findings that are dramatic, it moves you to severe. So base of skull fracture, just put that as severe. Okay. Always remember your C-spine. Okay. So in terms of treatment, our idea is to prevent secondary brain injury. And the way we can do this in the immediate setting is to avoid hypoxia and avoid hypotension. Those you can do. And then there's this head up position of nursing. Many times you come and find a head injury patient lying flat on the stretcher. That's a no-no. It will increase pressure. So keep in mind a very simple measure you can do. Elevate the head of the bed to 30 degrees. Not 20 to 30. In fact, people say 30 to 45. Elevate up to 30 degrees. And then if you have access to ICP monitoring, you go ahead and do that. And then you can give mannitol, hypertonic saline, prevent convulsions. And yeah. So what can we do? We know what is to be done. Number 1, quick diagnosis and quick referral to a neurosurgeon if that is needed, meaning a CT scan will be done as soon as possible. Keep the head up, okay? And if you're suspecting raised ICP, you're going to give some mannitol, and we're going to see how that's being given. You're going to give some hypertonic saline, actually 30%, over about 15 minutes. And we are also going to ensure that we don't have hypoxia. And if pressures are low, we're going to raise those pressures, blood pressure. So, some people say don't give intravenous fluid in patients who have head injury. Should you give intravenous fluid in head injury?
Yes.
Yes, you must. If the patient is hypovolemic, you must give IV fluids, and your target should maintain your pressures. If there's hypovolemia, you're going to have hypotension. Hypotension is very bad for the brain. It's the worst thing you can do. So correct hypovolemia. Ensure that you achieve a normovolemia, and then if need be, you can actually do what do you call these things? Endotropic support. Ensure your blood glucose is on point, but you do not give hypotonic fluids and you don't give glucose-containing fluids. Why not? Because glucose-containing fluids and hypotonic fluids, they go into the tissues and then they draw fluid into the tissues and they increase edema. Okay, so don't give hypotonic fluids at all. Okay? And check your sodium levels. Mannitol dose 0.25 to 1 gram per kg. Okay, there's a time limit for giving that, but in the acute setting, yes, you're able to give that, and it will decrease your ICP within 6 hours. It expands volume, increases oxygen carrying capacity, and also increases your diuretic effect. Okay, reducing intravascular volume. There's a role for Lasix 0.3 to 0.5 milligrams per kg, but should not be used in hypovolemia. Okay, because it's a diuretic, so you understand why that is the case.
Yeah.
Hypertonic saline, we're able to give just 30 mils over 15 minutes. Okay, in this setting, we're talking about a smaller concentration, but in fact, what we have in our unit is a 30%. Hypertonic saline must be given slowly, okay, and just a very small dose. And it can reduce your ICP significantly, increase your CPP, and your maps will generally remain stable. Okay. There's something people used to do in the past called hyperventilation in ICUs. It's very risky, so don't even try it. And I'm glad it's not being recommended in this particular situation. But you want to maintain your mean arterial pressure within normal. If you are to hyperventilate, 25 to 35 is what the target is, but this is very hard to maintain. So I'm very keen not to go that direction. So just completely avoid that for the time being. Barbiturates like phenobarbital are very important and could be useful, except that they're also not immediately to be used. The things that are being used last resort when the consultants are involved in that discussion. The anti-convulsants. This is the point that you wanted to know. If you have an acute convulsion that's ongoing, I know what we have here is diazepam, and sometimes people are concerned about giving diazepam because of neurostatus. You need to control the convulsion. Convulsions are not good for the patient. What you need to do is any patient who has a GCS of 8 and below, that patient is being intubated. Okay, and if this patient can maintain the airway, you intubate them for airway protection. So if at some point controlling convulsions means that the patient is completely unresponsive, then that is what it requires at that time. Okay, but if you are just preventing convulsions, you're not having an active convulsion, because phenytoin will take some time, then you give a loading dose of phenytoin, and the loading dose is 15 milligrams per kg. Then you maintain at 5 milligrams per kg. Okay, in an easier way to go about it is to give, for most patients, not even 15 per kg, just 750 milligrams for an adult patient. Just give 750 milligrams as a loading dose over 15 minutes in 100 mils, and then you maintain at 250 milligrams BD. Then you assess. Phenytoin should be measured, trough and peak levels. If you have a convulsion immediately, control that convulsion with what you have, the short-acting drugs like diazepam. But be aware, you may need to protect the airway as a consequence. Do not hesitate to give painkillers in patients who have head injury. People say, I can't give you morphine. The patient is crying in terrible pain, they've broken a leg as well as injury. You're saying we don't want to give pethidine, you can't give morphine because of yes, no, you don't do that. Assess quickly your GCS, then give your morphine if you have to give morphine. Is that all right? Mm-hmm. But make sure your pressures remain at a good level. So, that's all right. Yes. And always remember, to give something like morphine, the risk is airway. So always have ability to intubate. If you cannot intubate, that's when you avoid some of these drugs. You give other drugs intramuscularly if they're able to give you good, if they're able to give you good results. Is that all right? Okay. So surgical management is for the consultants. I will not get into it at all. And I think in a nutshell, I want to believe that we have gone through. Actually, right now we have a patient who has undergone what is called decompressive cranectomy. And when you look at his CT scan, can you see something is missing here? What is missing? The skull is missing. It was moved by surgeon. And it's this dramatic actually. You can see the brain is coming out, and as a result of that procedure, the patient has a chance. He was hit from behind by blunt head injury. He's done very well. He's been in the hospital now for about going to 10 days. We put a tracheostomy. It will take a long time for him to recover, but he's definitely better and out of danger. Then many months, 6 months to 1 year, something will be put there to cover that space. Okay, the long-term consequences of head injury, but that will be the next level. Some people think that head injury patients must die when the injury is very severe. This gentleman is called Phineas Gage, and it's an actual injury. Back in the late 19th century, he was blasting some rock in a railway track, and a metallic rod went through his head here. In the movies, when this happens, you die immediately. This guy lived. He died 12 years later. It went through his head through. Actually, this skull is on display in one of the universities, and this is him after recovering. Of course, he ended up losing the eye and a couple of things later to infection actually, and not even the immediate trauma. He was actually talking after this was removed. So your head injury patients, give them the best chance. We ever had a patient who was shot, this side of the head was completely gone, was brought in from Mogadishu many years ago as a young ICU doctor, and the patient survived. So those dramatic movie things, it's just a movie, someone has to die, but in medicine, that's not the case. Many of these patients can be saved. You don't need, you can live without half of the brain. You need it, but if you don't have it, that's not the end of the world. Any question? Alright guys, sorry we started late. I'm really asking that in future when we start plan for 7:30, we start at 7:30. Just that. Otherwise, I'll try and see if the recording has worked, so we can have a refresher if need be. But my hope is pick 2 or 3 things that you will remember. The highlights for this particular thing, that this discussion you have had. Number 1, GCS is something you must know. Tied to the previous discussion on trauma life support, primary survey, secondary survey, what you're doing, C-spine stabilization. Okay, then recognizing danger signs in head injury, raise ICP, to understand that you're keeping your perfusion at the right level. That's most important. You're preventing secondary injury. Prevent hypoxia, prevent hypotension, prevent metabolic disturbances, and ensure the patient is elevated and do not have any unnecessary delays. And you've done a lot for that patient just by those things. Then in terms of medication, if there's raised ICP, there'll be mannitol, there'll be hypertonic saline, there's going to be prevention of convulsions, and if there's leaking CSF, then maybe you're going to give some antibiotics in that case. But by that time you've consulted the consultants and you're good to go. You will know to distinguish the different levels of different levels of injury. Mild 14-15, moderate 9 to 13, severe less than 8, and 8 and below less than 9 in terms of severity of head injury. So, okay. Have you learned anything? Sorry, we've rushed towards the last question. Yes.
No, not a question. We have learned a lot.
Okay. But it's important, not important just to hear, but to remember something. So pick what you're going to remember so that at least there's value in that discussion. So, all right.
Could we have probably the slides shared in an email so that I can share the rest?
Yes, you will
Then
remind.
at least you can get the GCS put in the casualty so that you see continuous check on the walls. It's easier to remember.
I think I want to
We
task.
have that.
You have that?
Done that.
Okay, very nice. Let everybody understand GCS. If you're a nurse, if you're a clinician, if you're a doctor, GCS must be?
The fingertips.
Yes, fingertips. So, and it makes a difference because if you told me GCS is 8, I'm saying intubate the patient, yet you missed the GC, you've scored the patient wrongly. If you see the GCS is 12 and the patient GCS is actually 8, then okay, that's okay, observe, yet the patient needs an definitive airway. So getting GCS right is super important. Okay, and not just same GCS for the last person. Do your own GCS. The other person GCS was 14. That was true, but this was EDH, and now the GCS is 4, and you have not done your own assessment. So GCS must be something. Even in radiology, in the lab, pharmacy, GCS, Kevo, GCS hapo. Sawa. All right. Sawa guys. Thank you.
If you can share the email.
Yes, we will.